Tēnā koutou katoa. I'm called Derek Sherwood, tōku ringoa, no whakatua hao. He kai whakora, ka nohi, a hao, morera, tēnā koutou, tēnā tātou katoa. Thank you very much, Andrew, and I'd just like to reiterate your acknowledgement of the Indigenous people of Australia and Aotearoa New Zealand, and I think also recognise the poor health outcomes they have as a result of colonisation and inequitable healthcare provision. I'm Derek Sherwood, as Andrew says, I'm an ophthalmologist, but obviously probably I'm a frustrated public health physician and went into the wrong career. David and I are going to talk tonight a little bit about the background of Choosing Wisely, but probably more about the background of inequity and some of the problems, and I guess what we've learned from trying to incorporate equity into Choosing Wisely, which I think can be helpful as we look at, as you look at the Evolve program, but also as we look at other health innovations in the future. So just initially, how we're going to run this is I'm going to do a short background on how Choosing Wisely started internationally, how we came to have this in Australia and New Zealand, our relationship with Evolve, and then I'm going to hand over to David to talk a bit about the background of inequity in healthcare in New Zealand. I'll briefly talk a little bit about our early work around equity and Choosing Wisely, and then David's going to really talk about the report that Council of Medical Colleges and Te Ora co-sponsored to really look at Choosing Wisely and perhaps give some guidance about where we're going with this in the future. So low value care or inappropriate or unnecessary care has been around probably from the beginning of medicine. And if I think about my own, during my own life, you know, my first research project I ever did was looking at the value or lack of value of preoperative chest x-rays in Christchurch Hospital in 1980. And if I go back even further, my first experience of healthcare was having my tonsils removed when I was 3 years of age, at a time when almost every kid in the Western world had their tonsils removed. Probably for little benefit. So this type of care has been around for a long time. Choosing Wisely was developed by the American Board of Internal Medicine Foundation in 2012. And I guess they were responding to the increasing evidence of unnecessary care. This is a graph from a paper by Don Berwick in JAMA in 2012, just looking really at wasted healthcare expenditure in the US, the increasing amount of waste. And part of that was this so-called wedge of waste of overtreatment. And really it was that area that Choosing Wisely was developed to try and do something about. It's worth looking at this graph, though, that above that is also a wedge failures of care delivery. And I think when we start thinking about Choosing Wisely and equity, I think one of the obvious things is that disadvantaged groups in our community are perhaps more likely to have a failure of care delivery than they are to be overtreated, although there is some evidence to suggest that both exist in these disadvantaged groups. Low value care, apologies for the extra bullet point. These are kind of definitions of what it is, and I think we can all think of obvious examples within the areas we work of care that gives little or no benefit to patients, or care where the risk of harm exceeds the likely benefit. Care with a high cost is disproportionate to the benefit is probably more, it's more often seen at the cutting edge of medicine, high-tech surgery, new drugs, things where really the marketing tends to run ahead of the evidence base. There's a lot of factors that encourage clinicians to over-treat and over-test. The way we are taught, particularly I think in postgraduate teaching, as role models, we often tend to role model over-treatment. The way we fund healthcare doesn't help, particularly in fee-for-service medicine, but even in public hospitals, we're often there's an emphasis on doing stuff, volumes of work. There's a fear of complaint, and we certainly do get punished more for errors of omission rather than commission. You don't often see front page headlines of, my son had an unnecessary CT scan. And then patient and community attitudes to testing and treatment. There's a tendency to think that doctors that do more tests are being thorough, that doing something rather than doing nothing is inherently good. There's also this kind of belief in catching things early always is a good thing. And I think we in the health profession have tended to promulgate a belief in high-tech medicine. There's also the way our referral pathways work. I think often encourage the doctor receiving the referral that there's implied in the referral is a request for testing in particular. So I think the other problem is, especially when we think about screening for risk factors and then treating risk factors, which is a big part of medicine now, particularly in primary care. I think neither health professionals or patients often have a very good grasp of the statistics and of the risks and benefits. And, when it comes to making an informed decision about treatment, if as health professionals, we can't really explain or pass on that information, it makes it very difficult for patients to make the right decision for them. Going back a little bit to that comment about equity, I think, that unnecessary care and failure to get care that's effective are almost two sides of a coin, and choosing wisely clearly dealing with, tending to emphasise one, or the international model as developed in the US is emphasising one side of that coin. These figures are a little bit plucked out of the air, but they're based on some analysis done in the US and Canada. So roughly sort of somewhere around 15 to 25% of patients having an interaction with the health system are likely to get care that's not necessary or probably not in their best interest. But a bigger proportion fail to get treatments that we know are effective. And both these problems are problems not of knowledge of what the right thing to do is, but of implementation of what the right thing to do is. And certainly, one can argue that in terms of Indigenous people or people who have other are disadvantaged in other ways are probably more likely to fail to get treatments of proven effectiveness. In terms of the way the American Choosing Wisely was set up, it had two main streams of work. One was working with health professional organisations to identify areas of over-treatment or over-investigation based on the evidence, and then try and develop recommendations to try and change the behaviour of health professionals, within those organisations. And then the other stream of work was working with the community or with patients to try and encourage them to ask more questions, to change their attitudes about testing and treatment. And I guess, ultimately to try and get better conversations around care, better shared decision-making based on evidence, and trying to get the right treatment or test for the right patient. That the principles and the program has proved to be really popular internationally, and it's spread very quickly to now 22 countries. And there's a sort of loose international collaboration that's been largely driven by the Canadians, and they've developed sort of broad principles for these programs in different countries, but there's really a lot of freedom to modify your program according to how you want to deliberate, and you may not even call it choosing wisely. And obviously Evolve is an example of that, a program that's named differently but clearly providing going down the same path. So these are the principles that the international group have come up with. The important ones being that it's health professional led, that it's patient-centered, evidence-based, processes around developing a recommendation should be transparent, and ultimately it's multi-professional, so it's not just about doctors. They did previously have a principle which was that it should be about harm reduction rather than reducing cost. There are some countries that have been quite keen on having the sort of moral argument about resource stewardship included in their program, so I think that's why that one has dropped off. In terms of Australia and New Zealand, Australia was actually a very early adopter of choosing wisely, moving to introduce it in 2014. And that was through the organisation NPS Medicine Wise, who already had a role in pharmaceutical stewardship, largely with primary care. And I think, I'm not sure about the exact timing of when Evolve was developed, but I presume that started about that same time. And it's gone down a similar path of developing recommendations the different subspecialty groups about practice. We were a bit late in the uptake in New Zealand, so we were a year after this, and that had some advantages in the sense that many of our colleges are binational and they'd already got involved with the process, including the College of Physicians with Evolve. And so we were able to, with Evolve, co-badge lists of recommendations, which was great. And the same with some of the other colleges and choosing wisely in Australia. But I think the problem for us was that it meant that the New Zealand branches didn't go through the process of developing their own recommendations based on local evidence and that were appropriate for the New Zealand context. And part of another problem was that we were very aware that introducing something like this in New Zealand, that equity was a really important consideration, but it obviously hadn't been considered at the international level, and probably only to a small extent in Australia. So in a way, coming in late was a bit of a problem for us, and things were already rolling along, and it was a little bit difficult for us to start from scratch and really design this to be perhaps as appropriate as it could have been for the New Zealand context.
So good evening, everybody. It's great to be here. My name is David Tipene-Leach. I'm a GP and a public health physician, and at the moment I'm chair of Te Ora. And thanks, Derek, to give that little bit of an introduction on choosing wisely in New Zealand. One day we were having a board meeting and Derek came along to our board meeting and said, guys, this program is around and we are a little bit worried about whether a program that encourages shared decision-making between practitioners and their consumers is going to, in order to decrease unnecessary care, is going to have a problem with equity. So at the moment, so we joined with the Council of Medical Colleges at the time and the Choosing Wisely program in New Zealand to do a project. But this little presentation is just a background that talks about inequitable health outcomes in New Zealand, and it's almost as if inequitable health outcomes are a given across the world. We have big life expectancy differentials. We have in primary care amenable mortality, and ASH rates are hugely different between Māori and non-Māori, non-Pacific populations. And of course, if you go into areas that you ones in RACP will be more familiar with, kidney failure and transplants as first treatment, huge inequities and that sort of thing. We're all aware of the problems of stenting, coronary artery disease and stenting, and the disparities in that area. Recently discovered that we have problems in New Zealand with resuscitation of premature infants who are brown, Māori, Pacific and or Indian. and one that I spent some time working with the College of Radiation Oncology, that allocation to surgery versus radiation for lung cancer in this country is hugely inequitable. So that it's almost as if they are given, and they're given, it seems, across practitioners, as individuals, across services, across levels of care, across the life course. And of course, when you look at Indigenous things and socioeconomic things across those sorts of differences. This is my best friend, Paparangi Reid. She's a professor of Māori health at Auckland Medical School, and she says inequity is immoral. She says inequity is immoral, and we've got to have it more than just item 7.2 on our strategic plan. And so let's push on and have a little look. Let's have a look at the Institute of Medicine, who said when they were looking at trying to figure out why there were ethnic health disparities, they said there were health system factors, there were population factors, and there were health professional factors. And if we ask the question, dear me, here we go. And if we looked at those things in health system, if we thought that the health system was systemically unfair, and that populations were systematically disadvantaged, and that practitioners were in some respects incompetent, and we're talking about cultural incompetency here, then those are the things that lead to healthcare inequalities. So I've changed them slightly into institutional racism, the poor social determinants of health, and cultural incompetence of you and I as medical practitioners. And if we add the idea, because we're talking here about Indigenous populations, of being a colonised Indigenous minority, then that clearly is an extra problem. And so historical trauma is the fourth part of this framework of what the causes of Indigenous health disparities are. So here they are, institutional racism, where institutions produce outcomes that systemically put disadvantaged groups at further disadvantage. And it's kind of like, well, we know there's a racism problem, right? We all understand that personally mediated racism, that I don't like you, I don't like your kind, I don't like your colour, I don't like your eye colour, whatever the reason, I don't like your, it goes across into gender, it goes across into those other sorts of problems, and it's about me and you. And when those problems become systematically ingrained inside organisations, we call it institutional racism. It's almost like you can't have what I can get, and the way that you can't have what I can get is that we're going to set up a criteria. Let's, for instance, talk about BMI and whether you do or don't get a renal transplant. And suddenly what we've got is something that is institutionally racist and that stops a particular group of people getting a particular outcome. Internalized racism is when the victims of racism, they end up thinking, well, I don't deserve this, I'm not good enough for this, they're right not to give it to me, it's a waste of time, me putting my hand up and pushing forward. And so Kamara Jones, this work is Kamara Jones's work, Kamara from the United States of America. So reminding ourselves, yeah, we know that there is a racism problem because, hey, I treat all my patients the same, and it's not me. It's not me, no, it's my patient who smokes. Or it's my patient because, well, they won't take the pills that I tell them to take. Or they eat all the wrong foods, or they won't come when I tell them to come, and they can't keep their appointments, they don't do exercise, or indeed they've got bad genes. It's not my racism. And look, when I look at this, I look here and I see the things that I go to sometimes when I'm making excuses for myself in my own clinic. So, yep, there is a racism problem. And here we are, going back to this kidney failure and 10% of all transplants as first treatment, 2/3 of all kidney failure, 10% of transplants as first treatment, and renal physicians who say but patients need to be deserving of transplant. And they describe patients, Māori patients, as naughty. They describe them as difficult, and they do not bring in. We have cultural coordinators in all our hospitals. And what we found on when Māori Order did this particular piece of work, that the cultural coordinators were most often not involved in people with chronic end-stage renal failure who were being set up for the do we or do we not do a transplant type thing. So racism is alive and well. If we just flick across to a minute to historical trauma, this is a definition from the States: depression, self-destructive behavior, suicidal thoughts, anxiety, low self-esteem, and these sorts of things. And, you know, historical trauma is associated with colonization, where one group of people takes another group of people's resources. They come to your land, they extract things of value, they send that value back to the home country, and then often they go home, as they did in India. But in Australia and New Zealand, the colonist didn't go home. So, you know, in our country, we have a historical trauma that's associated with war. And the New Zealand land wars, the New Zealand land wars were 77 years long. They started in 1843, 3 years after the treaty was signed, in a place called Waitangi. And the last time that the armed forces of the state attacked and killed people in Māori communities was in 1916 in a place called Maunga. So it's been a 77-year-long war, and it's been an ugly war. You know, sometimes we say that we had a war between two groups of gentlemen, the native gentlemen and the British gentlemen, but we had Rangi Aowhia. Rangi Aowhia was where there was a church. The church, all the people were sheltering in the church, the old people and the kids. The church was set alight, and the people were shot as they came out the door of the burning church. The Taranaki Mounted Rifles in 1864 were a group of young farmers who had formed a cavalry unit. And in 1864, they did a major charge, and they sabred 11 rebels who turned out to be between 9 and 11 years of age, and they were armed with sticks. Parihaka is very big in New Zealand. In 1881, Parihaka was a peaceful pacifist community that was marched on by 1,500 fully armed soldiers with systematic rape of the women after the engagement. So, you know, we do have war trauma. We have land loss trauma. The black in 1860 was what we once owned. In 1908, you can see the small amount of black. In 1960, you can see the even smaller amount of black. And if I had one for 221, doubtless it would be even smaller. Land problems haven't gone away. February 6th and Waitangi Day, this was a major news story in our country, and it's called Our Truth, the Racist and Complex Laws Restricting Māori Land Development. And it was about a contemporary woman who had spent 36 years trying to build on her own land, but our modern land laws prevented that. So it's kind of like not gone away. Citizenship is a big issue in our country, and we felt that we didn't have citizenship. In the Second World War, some of our great politicians kind of like called the people together, sent them off to war in a unit that came, that was thrown into the heaviest battles and had the heaviest casualties. And when the Māori battalion came home, expecting to take part in the repatriation land draws, they came home to find that their lands, Māori lands, had been confiscated for white soldiers who had come back from war. So the people moved to towns. We had an urban migration where they found that they were prohibited from drinking alcohol in public. And when the unemployment benefit was introduced, Māori people were given lower rates of unemployment because they were expected to live off the land, which of course had been, for the most part, taken. So it's an interesting history that we have. And if you just follow this arrow around, you can see that wars, land loss, language loss, social structures broken down, marginalization, alienation from society, poverty, going away from your homes, falling into illness, into addictions, into abuse. And then you've got this, we have this modern epidemic, if you like, of mental illness, of incarceration, and presently of systematic baby uplift by the state that's presently being fought across the country. So it's an interesting thing that we have with historical trauma. The poor social determinants of health, well, I don't need to talk these up. We all understand the conditions in which people are born, grow up and live and work and age, including access to care, are really important as determinants of health. Healthcare, health behaviours, socioeconomic factors, physical environment. Sometimes you look at this slide and you're pleased to see that actually you and I as medical practitioners, we're really only responsible for 1/5 of this of this conglomeration of factors in the social determinants of health. Risk behaviour accounts for 1/3, other socioeconomic factors for 40%, and the physical environment around housing and the built environment accounting for 10%. So the social determinants of health are really important. And when you have a look at them, what you find is that it's predetermined health, ill health, and poor access to care, which are the problem. Here's perhaps the one that you and I could pay a lot of attention to: attitude, skills, and knowledge needed to function effectively when working and treating with people of different cultures. And it's, if we don't have it, it's called cultural incompetence. So there's been a gradation of these things. Cultural sensitivity is what I used to teach in medical school in the 70s. It was not very mandatory. It was about the individual doctor. And it was kind of like, you could be sensitive to Māori need, please, if you will, please. Cultural competence came in the 2000s in our country, and with the Health Practitioner Competency Act, and our schools and our colleges moved to introduce this and call it cultural competence. And it was a little bit more proactive and enforced, and it says you should really be on your game. You should really be on your game. Māori patients have rights. This is what you should do. We had MOPS points around this. Most often they weren't assessed, but we did have MOPS points around this. And cultural safety is a concept that we've borrowed from nursing, which is presently going sector-wide in this country. It covers individuals, it covers organisations, and it's really here saying you must know how your attitudes and your biases affect the outcomes for your patients. So that's kind of like the change, if you like, of this thing called cultural competence over the time. There's cultural sensitivity, often meeting, greeting, seating, eating, treating. Cultural competence, learning about other people's behaviour. Often in this country, it's about a little bit of Māori language. It's about learning about how Māori feel about health with these 4 cornerstones. We have a treaty in this country, and it's about learning a little bit about that treaty and perhaps visiting some Māori spaces and learning how to sing a Māori song. Arguably, these things are what any good Kiwi should really be doing, and they're not requirements for us to teach in medical curricula. So cultural safety is about focusing on the delivery of quality care and thinking through the changes in power relationships and patients' rights. Dr. Eddie Haupeti Ramsden was a nursing lecturer in our country. She introduced this in the mid-90s, and she got into hot water big time. It was not an easy introduction at all. So cultural safety, you look at cultural safety by doing systematic clinical audit by ethnicity and constant case review of outcomes. So these are some of the ways that you can test for cultural safety by what sort of results you're producing for Māori patients. I'm sorry about my mucking around with this thing. So here they are: institutional racism, the poor social determinants of health, cultural incompetence, historical trauma are the sorts of things that cause health inequities in our country. And the big question, I guess, is what do we do next? And later on, we're going to talk about what the Medical Council, Te Ora, and the Council of Medical Colleges have done about this. So kia ora, everybody.
So I'm just got a little brief, really introduction into David's next section, because and really I just want to emphasise here, I guess, as some of the failures are now early efforts to try and actually introduce equity into choosing wisely. So we had this concern that we knew that health innovation frequently increases inequity. When you start doing the same as what you've been doing better, then that often inevitably leads to more inequity. We were aware that we really needed to, just at the time we were introducing Choosing Wisely, I think there was a recognition, as David said, that we should be moving more to a cultural safety approach, that we should be looking at the outcomes of anything we're doing in terms of the effect on equity. But the difficulty for us, I think, was, as a lot of colleges have had, was trying to actually work out how you did this and how you really were effective. So, so we recognised that we needed to do something about choosing wisely because there wasn't really equity incorporated in the international principles. We tried doing the usual things of which I'm sure David will comment on as we look at the outcome of the report on Choosing Wisely, but we looked at trying to have a Māori representative in our steering group and consulting with consumer groups that included Māori. And at that stage, we made our initial approach to Te Ora. But I think where we ran into problems is probably a very common error by many health organisations, health services, and particularly those bringing in health innovation, it was kind of hard. There aren't, because of the history of inequity in terms of training of Māori as health professionals, many of the Māori doctors around are really overburdened. They're asked to be on every committee going. They're already busy doing their clinical jobs, and they're often also under pressure to be involved within their own communities. And so there aren't a lot of Māori health practitioners just hanging around waiting to be asked to have a governance role in a new initiative, especially one that they might have been suspicious about was going to make things worse. And the problem there is, we were under pressure, like people often are, to get on and get this thing going. And so we tended to just keep rolling along, hoping that we might eventually get our equity side sorted out. I think also the lesson I learned from this too was that, as well as the fact that you should stop until you have this sorted out, was I think you also need to have real representation or real governance involvement rather than just the token representation, which I think initially we would be quite reasonably accused of. The other thing we tried was tried to use, there's a health equity assessment tool available that we used really to try and see if we could tease out the potential problems and areas that we could change Choosing Wisely to avoid outcomes, increasing inequity. And out of that, I think that was quite useful. It certainly suggested that we should be targeting areas of health inequities for recommendations that would reduce inequity. Out of that came a plan that we would ask all the colleges to review all their recommendations to look for any where there was a potential to increase inequity. And I think it also kicked us on to actually go back to Te Ora because, as I said about individual Māori health practitioners, Te Ora is a small organisation that's got limited funding and again is being pulled in all directions to try and advise everyone from government departments to colleges to DHBs. And so I think that health equity assessment tool was quite useful in really encouraging us that we needed to actually keep trying to develop that relationship. And And there was where I think we turned a corner when we did, as David says, I finally managed to get in front of the board at about 4:30 on a Friday afternoon when they're all quite keen to get on the plane and go home. And out of that came this co-sponsorship of some, real research using a Māori kaupapa, to actually look at what we were doing and really identify the problems we had and maybe some ideas about where we should be going. And I think that was incredibly helpful. And David's going, this is the bit of work. It was the hard yards were done by a wonderful young Māori researcher, Anna Adcock, with David supervising and providing mentoring and advice. And I think this has been a really useful thing and quite a model for us, I think, is how we should approach research around health innovation, which is in a partnership and a collaborative way. So that's all I was going to say about it. David's going to share really the findings from that research and some ideas about where to go, and then we'll open it up for some questions and discussion.
So here's our choosing what. So we said to Derek when he came along, choosing wisely kind of means choosing equity, and if we can use that as our slogan, let's do a little bit of research around what happens in the environment when you've got Māori patients and practitioners together trying to do some shared decision making and making that shared decision making wise choices around that shared decision making. And so here's that same project that we did with the Council of Medical Colleges. So the question was, is doing less actually doing better when you've got a group of people who are under-resourced, under-serviced and have poor access? And we came up with this project. So the aims of the project were to inquire into the perspectives of Māori health consumers and Māori health practitioners on the Choosing Wisely program in New Zealand, and to try and explore shared decision-making between Māori patients and health practitioners. We used a qualitative methodology here, so we went out doing interviews. We used a kaupapa Māori methodology, meaning kaupapa Māori in a 30-second soundbite is Māori friendly, often by Māori, usually about Māori, and to make the best of Māori outcomes. So we used this kaupapa Māori methodology that Anna used, and we were scoping the experience of choosing wisely and the aspirations that people had around shared decision making with both Māori consumers and with Māori practitioners. So we had these participants who were purposefully selected through Anna's networks and other health networks in Wellington. And there were 8 consumers and 7 Māori health practitioners. They were one-on-one interviews, and we did a thematic analysis. So these things are the results that came out. And what we discovered when people went in to ask about the Choosing Wisely program, they asked around where did this come from, those sorts of questions. And what came out was it was critiqued as being a not very well adapted American program for New Zealand. There was some critique around the lack of engagement with Māori over the 2 to 3 years that Choosing Wisely had been around in our country. And certainly people noticed that there was no building at all on any Māori knowledge system or any Māori ways of doing things, which are kind of pretty basic building blocks in the New Zealand health system at the moment. Doing stuff that doesn't really take Māori on board and doesn't try to go some way to making this a Māori-like program or a Māori-liked program is kind of a little bit old hat. So we said that in the design, what you really needed, let me rephrase that. The participants said that Choosing Wisely really required a Māori lens across all of its activities in order to get these knowledge systems and ways of doing things going. And in particular, to be able to incorporate models of what we call in this country hauora, or health and wellbeing, it seems that hauora in our country is just a little bit wider than health and well-being, which is often thought of as physical and mental health of an individual, and yes, maybe a family, but hauora is definitely family-based. It's got spiritual concepts, it's got emotional concepts, it's got family concepts, the connections to the land, the sorts of things that we see in Indigenous peoples in our country and indeed in your country for those of you from Australia. Our participants, both health practitioners and consumers, said that we really also needed to incorporate Māori treatment options called rongoa, medicines and karakia or prayers, incantations, those sorts of interventions as reasonable treatment options. Now, I have to say that that wasn't particularly Choosing Wisely's problem, but it was certainly something when people have an opportunity to critique, those are the sorts of critiques they come up with. We looked at the message that was associated with Choosing Wisely, and we found really that it was too focused, really focused on reducing tests and treatments and associated costs. And our health practitioners in particular thought that it was much better to begin to stress the deployment of evidence-based medicines that provide equitable care that, that many of us understand as an ordinary part of everyday life when we're thinking of our usual patient that we see that doesn't kind of like stress us out because they have either spiritual or ethnic or cultural ways of difference. So, health practitioners also told us about the message and saying that the message around Choosing Wisely was in this country. So I noted that the Choosing Wisely questions that Evolve asked, the last slide that Derek had up, there were 5 questions there that really seemed, when I looked at them, to be around the health professional. But Choosing Wisely, the way that we met it and presented it to our participants using the information that came from Choosing Wisely, it seemed that the onus for change was on the consumer rather than on the health professionals. And our health professionals told us, look, it's providers, what they should really be doing is creating environments that were welcoming of discussions about treatment options, and that health providers are responsible for facilitating shared decision-making and providing appropriate care. Shared decision-making, our consumers said, required them to trust their health practitioner. It required them to have some degree of autonomy and agency around the particular actions that they were being asked to take. And if those things were not there, then they were left feeling anxious. They felt that communication was poor, and then felt many times that they were feeling that they didn't want to go back and re-attend that same practitioner. Now, consumers also said that they needed a sense of advocacy and they needed a sense of support. And these are a couple of, well, this is a quote, when they said, an extra face in the room makes a difference. And that extra face, some of those extra faces who were mentioned in our country are called whānau ora navigators. So whānau ora, Māori word for healthy family, and navigators are community health workers attached to health professionals and health professional organisations who help patients literally navigate our complex health system. Both of our participants, the health practitioners and the consumers talked about cultural safety as really important. That cultural safety was around trusting relationships that were non-judgmental, that were supportive, that were genuine. Cultural safety was about knowing that the Māori world was valued, and that people weren't, thinking you were a little bit odd because you felt a little bit differently about your health. The importance of relationships, we call it whanaungatanga here, but the connecting relationships, family relationships, indeed the relationship with your health practitioner are primary, are really important. and the centrality of holistic models of health, our participants told us were really important for them to be able to feel safe in an interaction. Our model of care in primary health in New Zealand was critiqued with poor continuity and very short appointment times. And our health practitioners suggested that we needed somehow to develop skills to identify the bias and to build cultural empathy, cultural safety, and to, oops, what happened to my screen? And to develop a more culturally safe health workforce. We have some teaching models in New Zealand, one being the Meihana model and the Hui process that we use in this country to be able to teach communication skills when you're in with a whānau Māori. We were able to get some indication of where the systematic gaps were from our health practitioner participants. And they said that providers didn't fulfill Treaty of Waitangi obligations. And Treaty of Waitangi obligations are interesting in this country. We talk about it a lot. Other people might look in and say, what's going on there? But it's a reasonably simple three-part treaty. And one of the parts says that you have the right to participate, you have the right to protection, including your health, and that you have the right to have a say. So the Treaty of Waitangi is kind of important in this country, even though some of us think it's a little bit too political. We often don't highlight health inequities for Māori. I mean, Derek and his team were a little bit different. They got it. Many of us don't. Many of our organisations are now getting it, but many of our individual practitioners, health inequities for different parts of the population are just too hard to think about. Tino rangatiratanga is another Māori political concept that we talk about in this country, but it's not rocket science. It's about self-determination. It's about a sense of autonomy. It's about a sense of being in control, in this case, of your own health, and it's a sort of approach that we ought to be taking in healthcare. And certainly both our practitioners and our consumers said that they just didn't see enough Māori in the health workforce. So the discussive items, I guess, were that this was the first time that Choosing Wisely or an Evolve-like program had ever looked at Indigenous programming and what this meant for equitable outcomes. We brought up concerns about governance, about decision-making, about input, about these principles of partnership, participation, protection, and equity with the Treaty of Waitangi. The ingredients for improved joint decision-making, we know they're known, they're out there, they are evidence-based. There's plenty of evidence around consumer trust, agency, autonomy, relationships, culturally appropriate resources, these sorts of things. And what we ended up saying is that actually there is no different. It is exactly the same. Those same pieces of evidence are the very things that point to the key to effective joint decision-making being a culturally safe environment for the health encounter to take place in. We think that cultural safety and good decision-making around what comes next has the potential to address health equities in a big way, certainly to liberate, if you like, the patient in the health encounter, but we acknowledge at the end of all this that the social determinants of health are huge and are fundamental to the inequity that we all see. So that's me, Derek. Oh, our last one. Health equity got to be prioritised. Relationships of rust, that of course means trust. Agency, a cultural safety environment are vital. Māori participation, Māori knowledge, and partnership in the way that Māori would understand with our treaty. So there we go. Thank you all. That was our piece of research that we did.
Thank you very much, David. So now to our audience, we still have a couple of minutes remaining, which we can address some questions. So there's still some time. If you'd like, to submit your question, please send that through to the Q&A tab. And we'll just wait a moment to see which come through there.
Can I ask David a question while we're waiting?
Please do. Thank you.
David, at the International Choosing Wisely Zoom meeting recently, Don Berwick was speaking and suggested that it's time that medical profession actually spoke out about the social determinants of health, and that it was part of being a health professional. Is that a line you'd agree with? I mean, that we have tended to stay in that area that we can do something about and leave it to the politicians for the rest.
Well, absolutely. I mean, our little social determinants of health graph showed that, well, I kind of tried to say that we were responsible for approximately 20% of that. That those are US figures and US diagrams. But Don's absolutely right. It's our fundamental responsibility. How do we solve SUDI in this country when we see what's happening as they're brown babies in deprived communities of town whose babies were sick at the time, living in overcrowded housing? How do we solve this? Well, we don't solve it by telling people to stop smoking and to put their babies on the back. The only way we're going to solve these problems is by addressing the social determinants of health and beginning to level out what's going on with income disparities in our country.
Andrew, have you found any questions yet?
No, so we haven't had any come through from our audience. Your presentations must have been so thorough and wonderful that it's answered everybody's questions already. But we are at the hour mark of our webinar this evening. So if we haven't had any questions come through yet, we might wrap up the presentation for tonight. Unless either Derek or David, did either of you have any closing comments that you would like to share with our audience tonight?
Yeah, I did. I wanted to say that all the way along the journey with the Council of Medical Colleges and with our Medical Council, that we have consistently and all the time met with groups of informed, curious, extremely hardworking health practitioners who are doing their damnedest to solve some of the problems of inequity. And so, it's not inappropriate of me when we're sitting here in the public to say to Derek, as in his time as the chair, thanks, Derek, it's been a good piece of work. And we've really enjoyed working with the Council of Medical Colleges. As you know, we've got 2 or 3 more pieces of work now lined up.
Yeah, thanks, David. I mean, my only comment would be, well, firstly to say that I think we are at a turning point. I think that there's some real efforts being made across healthcare to make a difference, which I'm really encouraged by. And I think I heard Pat Snedden actually talking recently. He's the chair of the Auckland District Health Board. And I think he used the term equity first. And I think that's one of the things I've learned is that we really need to, in any piece of work we're doing, put equity first, because otherwise, it tends to just slide past, we get on with what we're doing. So I think that's probably the main take-home message I've got is before we do any of this kind of work, we need to actually think about equity and the impact we're going to have on that. And that's probably a good takeaway message, I think.
I would definitely agree with that. Well, thank you both very much. And thank you to our audience for joining us this evening. That concludes tonight's webinar. And lastly, again, just a final very big thanks to Professor David Tipene-Leach and Dr. Derek Sherwood. Thank you, everyone. We'll see you next time.
Kia ora, Andrea. Thank you.
Thank you.